You know, we've come to Singing River Health System's medical centers for a few years now and met a lot of the wonderful doctors in the different fields I cover. Well, today we would like to introduce you to the latest addition to the medical team here at Singing River Health System, and that's Dr. Michael Finan, who's the gynecologic oncologist. How are you, sir?
Very good.
Elbow bump?
Yes, very
good.
Nice to be here.
It's nice to meet you. Give us a little bit of background about yourself, if you would, Dr. Finan.
Sure. I was born and raised in New Orleans, went to LSU Medical School, and then did my OBGYN residency in Tampa at the University of South Florida, stayed on there to do a fellowship in gynecologic oncology, and then was recruited to Ochsner. So I was at Ochsner for 13 years. Mm-hmm. And then I was recruited to Mobile actually 2 months before the storm in July of 2005.
Wow.
So I was at South Alabama for 15 years and just recently retired. And when word got out that I was retired, Singing River scooped me up. I had 3 months of retirement.
Enjoyed that 3 month while you can.
Yes.
Well, tell us a little bit about the research that you have done. And I understand you actually have some patents
yes.
that you have
that
pending.
were filed, right.
Yeah, that were filed.
We have 2 issued patents, a total of 6 patents filed. This was an idea we came up with in 2008, myself and my partner back in Mobile, Dr. Riccone, and one of the scientists there, Dr. Panel. We came up with the idea to screen for ovarian cancer. For decades, women have been having pap smears that the specimen is put in a little bottle of fluid, and the fluid is sent off to the pathologist. The pathologist for decades has been spinning down the fluid, the cells, looking at the cells, but throwing away the fluid. So we decided to look at the fluid to see if we could detect ovarian cancer, because essentially the fallopian tubes move eggs from the ovaries into the uterus via a fluid that's mostly made up of proteins. Mm-hmm. And that proteinaceous fluid, which is sort of like a mucus, comes out through the cervix, and we can pick that up with a pap smear. So we looked at the protein profile of this mucus and found some amazing differences between cancers and controls. So we're at the point now where we think we have enough data to go to the FDA and ask for approval for a test. We're still working on the final analysis, so we're not sure we're quite there yet, but we're very close.
Well, when it comes to surgery for cervical cancer, things like that, I mean, it's a whole different area as far as technology that you have to use. And right. I know you use the Da Vinci unit here to
yes.
do that.
Yes, I do. And about 60% of our cases are eligible for robotic surgery, as we call robotic surgery, which is done with the Da Vinci. The Da Vinci has 3 components. There's a tower that basically supplies the video, the camera, the gases that we need, and some of the technology. Mm-hmm. There's the actual robot itself, which has 4 arms, and those are what the instruments attach to, and the right. instruments go into the patient's abdomen. And then the console, which is where we actually do the surgery. So it's not the kind of robot where we put in 4 quarters, push a button, and go drink a cup of coffee.
If it was that easy.
That's right.
If that was that easy.
That will come one day, I'm sure.
Yes, I'm sure it will.
But right now, we still have to make incisions. You know, we still have to put the instruments in and the ports in, and then we dock the robot to the ports, kind of like the space shuttle docks to the space station. Mm-hmm. And then we sit at the console and do the surgery via the console. And we have 3D vision, so when we look in the console, it's an amazing view. You can actually see much, much better than the naked eye can see.
Right. Now, we've been here several times and seen some of the different doctors that you have here,
right.
and seeing how these things work, and it just amazes me that you're able to not even be hands-on so much with the patient, but yet you're getting a better view because of the Da Vinci system and and the robotic arms.
Right, and it's if you think about it, if you put your hand right up to your eyes, you lose your ability to focus.
Right.
But you can move the camera in that close and get amazing focus. So you can see on a level that you really can't even see with the naked eye.
Well, that's like I do photography as a sideline, and depending on the lens, you get, like you said,
right.
a certain distance, and no matter how much you adjust,
right.
it's not going to sharpen.
Right.
But with this,
yeah.
You can get right in there, right up.
It's amazing.
Up close. What about some of the targeted therapies or personalized treatments that you work in?
That has exploded in the last few years. Essentially, when I started my training, we had a handful of drugs that we could use, a handful of chemotherapy agents that we could use to treat various cancers, various gynecologic cancers. And gynecologic oncology is one of the unique surgical specialties. We're the only surgical specialty where we administer our own chemotherapy. Most chemotherapy is given by medical oncologists, not surgeons. And so, for example, a surgical oncologist that operates on a breast cancer would then send the patient to a medical oncologist to treat the breast cancer with chemotherapy. With gynecologic oncology, we do everything both surgically and medically. So, fast forward to 2020, we now not only have dozens of chemotherapy agents, but also dozens of what we call targeted agents or molecular therapy. And if you can think of it like personalized medicine. So if you look at a tumor, a particular tumor, it looks a certain way under the microscope. And traditionally, we would treat the cancer based on the way it looks under the microscope. Now we can send that tumor specimen to various companies that do molecular testing or genomic testing, and they will report back dozens, if not hundreds, of what we call actionable targets. And those essentially are like light switches. A common example is tamoxifen for breast cancer. That drug's been around a long time. It's a pill, and it targets estrogen receptors. So if the estrogen receptor is turned on, like a light switch turning on, the cancer grows, but tamoxifen can turn that switch off. So now we basically have dozens, if not hundreds, of those type of targets.
We got about a minute left, so if someone would need to see a gynecologic oncologist, does she need to get a referral from her primary physician?
It varies. If she has, if she's newly diagnosed, then definitely she needs to talk to her healthcare provider and ask for a referral. But women can call themselves. Like, let's say there's a woman who's being treated currently for a gynecologic cancer and she just wants a second opinion.
Right.
Or let's say she has a strong family history of female cancers and she wants to meet with me, she can call herself.
Okay. Dr. Finan, thank you so much. Welcome.
Thank you.
To this wonderful family of Senior Health System, all the doctors I've met here, and all the knowledge that they have. And again, if this is something that you need to do, you can call them here. You call the number on your screen, call your primary physician, set up an appointment, and find out more about the different options that they have for you here at Singing River Health System in Pascagoula.